it depends on user.
Oh, okay. All right. What are we aiming for? Like 45 minutes?
Pardon me?
How long are you aiming for? I mean, I can go a little bit longer, a little bit. What are you aiming
The
for
scheduled time,
ideally?
yeah, the scheduled time is for 30 minutes, 30 to 35 minutes, and it will be followed by the question answer session for 15 minutes. So you
Okay,
can
so
finish by
30 to
35
35.
minutes.
Okay, got it.
Yeah.
All right, gotcha. All right, so when should I start? You tell me.
So you can start now.
I can start? Okay, great. All right. Hi, my name's Luke Laffin, and I'm from the Cleveland, Ohio, and I work at the Cleveland Clinic, where I'm a preventive cardiologist. It's my pleasure to speak with you today about a topic that's near and dear to my heart, which is resistant hypertension. It's a privilege to speak with you today, and I'd like to thank the organizers, Cadila Pharmaceuticals, and then our chairperson, Dr. Manchanda, as well as our moderator, Dr. Mohan. So without any further ado, let's get on to the slides. So what we're going to start with is a case, okay? It's a 57-year-old lady. She's got hypertension. She has hyperlipidemia, and she just had an inferior myocardial infarction and a stent placement to her RCA. She comes to your office. She's sitting, and her right brachial blood pressure is measured at 153 over 94 millimeters of mercury, and her heart rate is 72. She's on the following blood pressure medicines. She's on an ACE inhibitor, a beta blocker, calcium channel blocker, and hydrochlorothiazide. And the question that I always pose to individuals is, based on this information, does she have resistant hypertension? And the answer is, one of these. But I would actually argue that the real answer is we don't have enough information, okay? And to that end, we're going to talk about today is resistant hypertension, really the approach to difficult to manage primary hypertension. So what we're going to talk about is, very briefly, we'll start with the recent blood pressure guidelines, really touching on some of the differences between American and European blood pressure guidelines. Then I think much more impactful is this 2018 document produced by the American Heart Association. It's actually a scientific statement talking about resistant hypertension. Then we'll talk specifically about some definitions, follow up with out-of-office blood pressure monitoring, and then finally talk about blood pressure management. So here's the guidelines in a nutshell. The most prominent two worldwide guidelines are the American, so American Heart Association, American College of Cardiology, published in 2017. And then in contrast below that on the slide, you can see the European Society of Cardiology, European Society of Hypertension guidelines. The real difference between these is just the definition of where we actually start calling someone a hypertensive or having hypertension. American guidelines downshifted that, whereas European guidelines still say that 140 over 90, greater than that is grade 1 hypertension. Americans now 130 over 80. Sometimes when we think about these and we're talking about these, it's important to remember that that's predominantly office-based blood pressures, because that's a lot of what our data involves. There's a nice table in the most recent blood pressure guidelines, American blood pressure guidelines, that really shows corresponding values between clinic blood pressures versus home blood pressure monitoring versus 24-hour ambulatory blood pressure monitoring. And so it's a nice reference, and it's important, and this point comes up time and time again, to not simply rely on clinic blood pressures, but to also corroborate with out-of-office blood pressure measurement as well. And this gives an idea of equivalencies. If you really want to read one guideline perspective on blood pressure guidelines, I'd suggest you take a look at this from a couple of years ago in New England Journal. It's short, it's about a page and a half, but it really talks about the new blood pressure guidelines and how do we put them in perspective. And really they focus on four major things which are important to emphasize. Number one is really we have to make sure that we're measuring blood pressure properly. It can't be done haphazardly. Number two, there's an emphasis on out-of-office blood pressure measurement, which we'll talk about later in the talk. Number three, we talk about assessing cardiovascular risk, which is new in these blood pressure guidelines, and that really should be how we intensify or how aggressively we treat blood pressure. And then one thing that they mentioned that is really neglected or absent in the American blood pressure guidelines is a lack of discussion of isolated systolic hypertension, which is important to note. Now, as I mentioned before, a document that's much more high yield for specialist consultants is this 2018 scientific statement by the American Heart Association about resistant hypertension. Now, important to understand that this is a comprehensive update. It's about 10% the size of the 2017 American blood pressure guidelines, so it's about 20-25 pages, and it's really their first update since 2008. And so we gained a lot of information over that decade about different factors associated with resistant hypertension and different ways to treat it. It covers all the topics on the screen, but what we're really going to focus on today is these four: definitions, proper diagnosis, lifestyle, and then management, which are going to be most important on an everyday basis when we're seeing patients. And when we talk about management, we're going to focus predominantly on drugs because device-based therapy for resistant hypertension, at least in the United States, is strictly experimental at this point. No one's using it for actual clinical practice, given that no large-scale sham randomized control trial has shown benefit. So let's talk about some definitions. So resistant hypertension, as many of us know, is above goal elevated blood pressure in a patient despite taking 3 different classes of antihypertensives. And commonly we think about the first 3 that we should be starting is a long-acting calcium channel blocker, a blocker of the renin-angiotensin system, so a so-called ACE or ARB, and then a diuretic. And these need to be administered at maximally or maximally tolerated doses. It's important to also remember that resistant hypertension can also be present, and it's called controlled resistant hypertension if a patient has controlled blood pressure on 4 or more blood pressure lowering medications. There's all kinds of terms that get thrown around for resistant hypertension. Some people call it refractory hypertension, and they use those terms synonymously. I would really caution against that. Refractory hypertension has its own definition that's been really bandied about within the past year or so. And refractory hypertension is defined as an extreme phenotype of antihypertensive failure, and that's people that we can't control their blood pressure on 5 or more meds, and they're on chlorthalidone, a long-acting thiazide type diuretic, and a mineralocorticoid receptor antagonist as well. It's important to make this distinction because there's good data that refractory hypertension is really driven by heightened sympathetic tone, whereas resistant hypertension, as many of us know, is oftentimes driven by excess volume. And we treat those a little bit differently. You'll see in some of the literature this term apparent treatment resistant hypertension, and that's really prevalent and really is proper to use if we don't have one of the 3 following data elements that we can confirm. So if we don't know their specific medication dose, so are they on the maximum dose tolerated? If we don't have information about adherence, such as directly observed therapy or urine studies to look for drug metabolites, or we don't have out-of-office blood pressure measurements, then we can really only call a resistant hypertension apparent treatment resistant hypertension rather than true resistant hypertension, because we cannot exclude pseudo-resistance. And this is really a challenge because a lot of studies don't have all this information available, and we don't really know what the true prevalence of resistant hypertension is. So how do we make a proper diagnosis of resistant hypertension? This is really important. So this is a nice flow diagram from those 2018 scientific statement. And really what we need to do first is we need to make sure people are on maximal or maximally tolerated doses, as I mentioned, of a long-acting CCB, a blocker of the renin-angiotensin system, and a diuretic. And then we have to exclude pseudoresistance, like I was talking about. So confirm adherence and perform out-of-office blood pressure monitoring. These are really the most common causes for pseudo-resistant hypertension. And this was published in 2016 in the Journal of American Society of Hypertension. So we have medication non-adherence, white coat effect, undertreatment, and inaccurate blood pressure measurement. So medication non-adherence. I think one take-home tip that is really helpful, particularly in the United States and likely in India as well, is really focusing on using drug combinations or fixed dose combinations. There's many available out there, and they help not only with synergistic effects of the two classes of medications, but they help with patient adherence, okay? Someone's much more likely to take one pill that has 2 or 3 medications in it rather than take 3 different pills if we're trying to control their blood pressure. So I'd encourage you to use it. European guidelines actually recommend most people start on fixed dose combination therapy, and it really comes down to this adherence issue as well. Really what we look at as the best combination to start people on is benazepril amlodipine, and that's from the ACCOMPLISH trial published in 2008. And here's the reference. Those patients ultimately did better from a cardiovascular risk reduction perspective. When we think about other causes for pseudo-resistant hypertension, undertreatment is clearly there. And that's multifactorial. There's inadequate dosing oftentimes, but there's also treatment inertia. Someone comes into our clinic, maybe their blood pressure is 135 over 81. We may say, oh, you're a little anxious, or, I don't want to make that change because you're doing well. Well, that's really what we call treatment inertia. We really should be being more aggressive based on the most recent American blood pressure guidelines, at least. This is not just anecdotal. We actually see this. So a nice study published in 2013 showed that almost half of patients, less than half of patients with uncontrolled apparent treatment-resistant hypertension in a large community practice network actually had an optimal antihypertensive regimen. The majority were given a diuretic, which is good. However, antihypertensive medications were administered at typically less than 50% of their maximally recommended dose. So we can't have that. We have to maximize the dose tolerance as much as possible. Interestingly, patients were more likely to be prescribed an optimal regimen if they were Black, had chronic kidney disease, had diabetes or other compelling factors, rather than if they just had simply hypertension. When we talk about other factors associated with pseudo-resistance, we want to talk about white coat effect as well. Okay, 2017 blood pressure guidelines really make it clear. Clinic blood pressure measurement unto itself is not sufficient for managing hypertension and for the diagnosis of hypertension. We have to do some degree of out-of-office blood pressure measurement for the diagnosis, and then ultimately for titration of medications. And this can be done in a couple of forms. It can be done in home blood pressure monitoring or 24-hour ambulatory blood pressure monitoring. Why is this? Well, this is a really important screen, okay? We all know that you can have different blood pressures in the office and out of the office. If you have concordant blood pressures in the office, you're going to have either sustained hypertension or normal blood pressure, essentially. But if you have discordant blood pressures, where perhaps out-of-office blood pressure is high and in-office blood pressure is controlled, that's called masked hypertension. Or the alternative, which people are more familiar with, is when office blood pressures are uncontrolled or elevated, and out-of-office blood pressures are actually controlled. That's white coat hypertension. So these are not benign conditions, and I'll show you a little bit of data on percentages of them. But those are not a few percentage points. When we think about the general population, it's probably somewhere between 20 and 40% based on published data that has this discordant office and out-of-office blood pressures. When we measure out-of-office blood pressures, there's a few different modalities we can use. there's the benefits really of ambulatory blood pressure monitoring are pretty clear. We can look for MAST, we can look for white coat hypertension, we can assess blood pressure overnight. So if possible, if it's available, it's a great tool for individuals to use. The only problem is it's not necessarily always available, and purchasing these machines can be expensive. But it can do all these things very well and oftentimes better than office or home blood pressure monitoring. For those of you that aren't particularly familiar with ambulatory blood pressure monitoring, this is a nice little description of what we see, or a representation of what we see. This patient was referred to me, and this is a clear representation of, if we're basing it simply on office blood pressures, we would overtreat this lady. I think she was about 88, 89 years old. So her home blood pressures, other than being elevated while she sleeps at night, are actually generally pretty well controlled. So they're not up in the 190s, 200s, which we see in the white coat period, which is on the left side of the screen there. So important to understand that. As I said, MAST hypertension is not a benign condition. This is actually in a Japanese population, published a couple years ago. As I alluded to earlier, if they looked at their total cohort of patients, almost 35% of them had discordant office and out of office blood pressures. So 19% had MAST, and almost 15% had white coat hypertension. So it's not the majority of people, but if you're seeing 10 patients in a clinic day, somewhere between 3 and 4 of them are going to have these discordant blood pressures, and you're going to be treating them incorrectly if you're not using out-of-office blood pressure management. And what they looked at when they did some modeling was that at least MAST hypertension in this cohort definitely increased the risk of stroke events. And then there's other studies looking at MAST hypertension in the Dallas Heart Study, which also shows similar adverse cardiovascular events. White coat hypertension is not a benign entity either. This was a nice systematic review and meta-analysis published last year in the Annals of Internal Medicine. And what it showed was those individuals with truly white coat hypertension had worse or increased risk of cardiovascular events than your normal population, okay? What they showed was people with white coat effect, meaning they have regular primary, or they have hypertension, but also an elevated blood pressure in the clinic, white coat effect, didn't see this increased cardiovascular risk. And there's multiple theories for that. It's probably because as practitioners, as physicians, we tend to blow off, or at least push to the side, maybe a little bit more of this treatment inertia, like I was talking about, elevated blood pressures if someone carries a diagnosis of white coat hypertension. So, but if they have white coat effect, they're likely monitoring at home, okay, because they have underlying hypertension. So it's important that we use out-of-office blood pressure monitoring, and we watch these patients that are diagnosed with white coat hypertension and make sure they don't transition to sustained hypertension. And that was ultimately the conclusion of this review. So what do we tell patients? Okay, it's a great guideline, but what do we tell patients? Well, this is really just for reference, so you can take a screenshot of it. You got to make sure you're checking your blood pressure correctly. And oftentimes I'll print out information for my patients so that they can just take it with them when they come home. When do you want to check blood pressure? You want to check it first thing in the morning before medications. That's really when we're seeing the early morning blood pressure surge, and that's represented in a lot of literature. And so I tend to tell patients to take it before they take medications in the morning. So if they're controlled, it essentially means that they're controlled throughout the rest of the day. These studies are a nice representation that this is also when patients are at highest risk for strokes and heart attacks, is that early morning period after that early morning blood pressure surge. And that's also when plaque is more vulnerable, atherosclerotic plaque. So this is a good time to make sure that blood pressure is controlled as well. When you do check blood pressure at home, I really emphasize multiple readings. Any good blood pressure study that's been done doesn't take just one measurement. They take 2 or 3, and it's pretty consistently, you'll see the second and third are lower than the first. Where's out-of-office blood pressure measurement headed? Well, this is a nice website sponsored by the American Medical Association, gives all the devices that are validated within the US, the UK, Canada. They have other sites that do this as well. This has about 15 devices that have been well validated and can be used at home. This is what we're talking about when we're talking about increased technology or furthering technology for blood pressure measurement. Upper right-hand corner is what's the technology that's most prevalent or most furthest along. And that's actually a watch that measures oscillometric radial blood pressure. It's by Omron. But all these technologies are coming down the pipe within the next 5 to 10 years. Now, that's just measuring blood pressure, which is vitally important, but we also got to talk about management. This table is taken directly from the AHA 2018 statement. I think it's important to focus on this. Even as a hypertension specialist at the Cleveland Clinic, 70% of my time is actually spent just emphasizing steps 1 through 3 here. And we're going to talk a little bit more about these. 30% of my time will be doing the less evidence-based steps 4, 5, and 6. But really, the fundamentals are so important to controlling blood pressure. And so I really want to focus on those. What do we have? And we're going to get back to some specifics of that. But I think it's really important when we look ahead for what are we going to be using for blood pressure in the future. Much like we're going to start using more small interfering RNAs for a measurement or for control of cholesterol, like inclisiran. There's ongoing studies looking at siRNAs for angiotensinogen in the liver to treat patients with hypertension. This is a phase 1 study that's currently wrapping up. I think it's going to be talked about at the most upcoming American Heart Association scientific sessions, and phase 2 and phase 3 trials are in the planning stages. And this is what it does. Okay, so really what is really important for these patients is to focus on, with resistant hypertension, if we've excluded all those pseudo-resistant causes, is to really focus on a discussion about lifestyle. So vitally important. So vitally important that this table right here has been reproduced in every American blood pressure guideline since 2003, okay? And these are all class 1 recommendations, and they have been for many years. And really what we focus on is these, because these have the best data for reducing blood pressure. So lowering dietary salt, which we'll talk about, making sure patients are getting enough dietary potassium, making sure they're getting regular resistance and aerobic physical activity, and making sure we get them to an ideal weight and they're not consuming excess alcohol. And that's all here for your review. One question you may have is, well, how do I get through all that lifestyle components in a short 5 to 15-minute visit with a patient? Well, if you want to focus on one thing, you really want to focus on sodium intake. I like to say it's truly a 4-letter word because there's all kinds of salt out there, all different colors. There's like 100 different types of salt, and they all raise blood pressure the same. This was a nice study showing this, that systolic blood pressure is greatly affected by sodium intake. We also know that as individuals age, they become more salt sensitive. So that's really defined as shifting the dose response curve between a given amount of sodium intake and blood pressure rise. So the same amount of salt that someone may have ate when they're 50 years old may not have affected their blood pressure very much. But guess what? By age 70, it may have a bigger effect, okay? Also, patients with chronic kidney disease tend to be more salt sensitive. African Americans are more salt sensitive. And then those patients with diagnosed resistant hypertension tend to be more sensitive to sodium as well. So what do you do? Well, I could tell them just eat less salt, but that can be difficult to do, and patients really aren't as educated as we'd like about how to actually do that. So what I ultimately tell them is we want to limit ourselves to 1 level teaspoon of sodium a day, or excuse me, of salt, and that's equivalent to less than 2,300 milligrams of sodium, okay? There is a little bit of controversy about how much sodium is too much, okay? And there's a variety of studies. This was a 2016 study published in The Lancet looking at about 133,000 patients. And it looked like there's really a sweet spot in terms of sodium intake for those patients with hypertension. And those patients that have more tend to do a little bit worse. Those patients that have severely decreased or severely restricted sodium intake tend to do a little bit worse. No such relation was seen for patients without hypertension. So there's not necessarily a limit on sodium intake for patients without known hypertension. The DASH diet is really the best study that we have and the DASH diet with no low salt, which was a following or an iterative study to the original DASH diet study, is really the best data that we have for sodium reduction, at least in an American population. So what are the sodium recommendations? Well, these are the current guidelines. AHA says no more than 1,500 milligrams daily. The resistant hypertension guidelines, as I said, about 1 level teaspoon of salt, which is equivalent to between 23 and 2,400 milligrams of sodium daily. Important to realize the difference between these is only about 2 or 3 blood pressure points, so it's not a huge amount. Most people, at least in North America, do not get the majority of their sodium from the salt shaker. It's mostly in the foods that we eat, the processed foods. As I referred to earlier, the DASH diet study is another thing that the original DASH diet, important to realize, was not a low sodium diet. So it's just important to understand that. That subsequent studies, I think it was published in 1999, so a couple of years later, showed that a low sodium diet on top of a DASH diet actually did better. And this is just a little bit of a look of what happened to blood pressures with the DASH diet. So the DASH diet was essentially, it's in here, it's called the combination diet, but it's a low fat fruits and vegetable diet, essentially. And so that's why it's focused on here in this table, okay? So we focus on sodium intake, that's number one. The other thing that we really focus on from a lifestyle perspective is sleep. This is anecdotally, we saw this patient in clinic a number of years back now, and blood pressure was well controlled until about the 13th, and then blood pressure went way up. Well, you know what also went up was her heart rate, and that really suggested that there's some excess sympathetic activity. So we dug a little bit deeper and found out that, guess what? The night of the 12th, she slept really poorly. She only slept for about 4 or 5 hours. And then by the 15th, night of the 15th or night of the 14th, excuse me, she was back to sleeping regularly. So there can actually be pretty profound effects just based on poor sleep. It doesn't just have to be sleep apnea. There's all kinds of sleep disorders that can contribute to not only poor quality sleep, but poor quantity of sleep. Both of those stimulate the sympathetic nervous system, stimulate the renin-angiotensin system, and ultimately lead to loss of nocturnal dipping pattern in blood pressure and potentially hypertension or exacerbation of hypertension. As I mentioned previously, it's not just obstructive sleep apnea, variety of causes, and it can really present almost as a labile or a paroxysmal hypertension picture if someone is getting really poor disrupted sleep, particularly long term. So when I see patients in clinic with resistant hypertension, after really focusing on the lifestyle component, we talk about their medications. And informally, I really like to group them into 4 major categories of resistant hypertension patients. And this is really the way that we deal with them. So we're going to go about these one by one. So when we think about salt sensitive, we really got to think about diuretics. And I talked a little bit about salt sensitivity previously. So this is from the prior slide. But when we think about those salt sensitive patients, we really want to make sure that we've substituted an optimally dosed thiazide type diuretic. Chlorthalidone is really the preferred, not only because it lasts, its half-life is 48 to 72 hours, but it works down to an estimated GFR of 25 to 30. So that's really helpful. And we can get almost 7 to 8 blood pressure or millimeters of mercury of systolic blood pressure by switching from hydrochlorothiazide to chlorthalidone. Indapamide is also a choice, which I like to use. It's a little less effective than chlorthalidone, but a nice compromise, and doesn't have the hypokalemia that chlorthalidone induces. Obviously, below a GFR of 30, then we're going to have a lot less predictable effect from thiazide type diuretics. And there we should be really using loop diuretics such as torsemide. So you got to make sure patients are taking that. Important to also understand, and this is a really old slide, but really important, that the blood pressure lowering effect from thiazide type diuretics is actually long-term due to decrease in total peripheral resistance and is not due to decreased plasma volume, okay? And so that's important. Even if they don't look edematous on exam, it is important to continue it long-term because their effects in terms of blood pressure control are not simply edema, they also decrease total peripheral resistance long-term. We also know that chlorothalonone in vitro studies has some pleiotropic effects, much like we talk about pleiotropic effects of statins, and they impact platelet aggregation and vascular tone. And so they can be helpful, and that's why some data may suggest that chlorothalonone prevents recurrent strokes. So that's the salt-sensitive patient. How about the hyperadrenergic patient? And these are these young patients with elevated heart rates. And that's when we really got to go back to this idea, are they sleeping well? Are they having a lot of stress in their life? And how do we best treat them? Well, really with beta blockers is our great choice, okay? You're going to look, or someone's going to tell you, oh, we should look for pheochromocytoma. It's really such a rare diagnosis that we rarely see it. But oftentimes hyperadrenergic patients tend to respond well to low-dose beta blockers, non-dihydropyridine calcium channel blockers, and then, if needed, central sympatholytics like clonidine and guanfacine, okay? Now, adding in some resistance activities, et cetera, because we know that long-term physical activity actually decreases sympathetic activation, can be really helpful. So focusing on that, giving them an exercise prescription or encouraging them to get more physical activity is important. Now, what about the obese patients, the ones that may be more renin-angiotensin system activated? They may have more inflammation, more of this central adiposity, so to speak. In those folks, we think about a RAS blocker. We know that these fat cells around our abdomen are metabolically active, okay? They're secreting all kinds of things. And really, overstimulation of the renin-angiotensin system leads to high renin levels. What we want to know in these folks also is that we're going to give them a RAS blocker like an ACE or an ARB, preferably a long-acting ARB that's effective. We got to know that these individuals also, because they're obese and have other cardiovascular risk factors, have a higher incidence of diabetes. So we don't want to worsen that with the addition of certain diuretics and beta blockers. So these are good folks for a dihydropyridine calcium channel blocker plus a blocker of the renin-angiotensin system. And then probably most importantly for our discussion today about resistant hypertension is we got to also think about patients with inappropriately elevated aldosterone. Then we think about adding mineralocorticoid receptor antagonists. So this is a nice flow diagram from a publication in Circulation, a review of primary aldosteronism in 2018. Now, the patients that I'm talking about, they don't meet criteria for primary hyperaldosteronism, but they will typically demonstrate a low renin state due to with high, normal, or slightly elevated aldosterone levels. And they may have a low potassium in this, even while taking a high dose of an ACE or an ARB. And so although they may not meet the strict definition of primary aldosteronism, they're going to do better with the addition of a pleuronone or spironolactone. Now, we know that step 3 of managing resistant hypertension after we maximize their thiazide-type diuretic, focus on the lifestyle, is adding a mineralocorticoid receptor antagonist. And this comes to us from the Pathway 2 trial, which looked at the difference between spironolactone, doxazosin, and bisoprolol. And over the vast majority of serum renin levels, spironolactone was most effective at lowering blood pressure. This is this idea of inappropriately elevated aldosteronism is also seen in a very recent publication in the Annals of Internal Medicine from about spring of this year, which showed that we want to not think about primary aldosteronism as strictly a binary equation, because it's really a spectrum of disease. And it doesn't matter if you have patients that are normotensive, they're stage 1, stage 2 hypertension, or if they're treatment-resistant hypertension. There's quite a spectrum of primary aldosteronism. And that's probably why the use of mineralocorticoid receptor antagonists was so good and so well tolerated and so effective in patients like those enrolled in the Pathway 2 trial. I don't hesitate to screen the vast majority of my patients with resistant hypertension for primary aldosteronism. So you look at an aldosterone-renin ratio. Important to realize that very few things that your patients are going to be taking are actually going to provide false positives. Okay, they're more likely to provide false negatives. So it doesn't hurt you to at least screen them. And if we see that there is an elevated aldosterone to renin ratio, even while they're taking an ACE or an ARB or a mineralocorticoid receptor antagonist, that's even more compelling information that they may have primary aldosteronism. And then you have to go down that pathway in terms of secondary hypertension and how best to treat it. Now, once we get through steps 1, 2, 3, and 4, 1, 2, and 3, we go to steps 4, 5, and 6. They're easy to read right here. I'm not going to spend a lot of time on them because really they're expert opinion only. Okay, there's not a lot of data to guide us. We got to think about that hyperadrenergic state, like I talked about for step 4. So if your heart rate's hanging out in the 80s and 90s on the above medicines, that's the time to add a beta blocker and a 9-dihydropyridine calcium channel blocker, which you can sometimes use in combination with a dihydropyridine calcium channel blocker as well. And then I typically add additional vasodilators as recommended here. Okay. One thing that's also important to note is that if you're going to get patients controlled on antihypertensive medicines, we have to know that they're going to have side effects. These medications are not benign. And really, we got to think about, well, how do we address them up front? So number one, patients that have cramping, particularly when we switch them from hydrochlorothiazide or something like that to chlorothalidone, what I tell them is if you watch your sodium intake after the first couple days of taking chlorothalidone, you're going to feel fine. Okay. But if you're cheating on salt, what's going to happen is you're going to continue to dehydrate yourself. And so important to just have that discussion up front with them so they don't stop chlorothalidone after a day or two. Lower extremity edema, commonly caused by our dihydropyridine calcium channel blockers. Remember, we don't treat that edema with a diuretic. That's the wrong thing to do. Best data is get rid of that edema with an ACE or an ARB. Hypokalemia, don't be the, unfortunately, a lot of cardiologists like the old diuretic beta blocker combination. Not the best choice for preventing hypokalemia. So especially if you're on one of these more potent thiazide type diuretics, like an indapamide or chlorothalidone, what we really want to focus on is pairing that with a mineralocorticoid receptor antagonist or perhaps an ACE or an ARB. And those will help obviously raise serum potassium. And then finally, any discussion of adding ACEs, ARBs, et cetera, would not be complete without talking about the fact that we can see a serum creatinine elevation. There's no question about it. And that can be expected to be seen in a large percentage of people. We tolerate up to about a 30% increase in serum creatinine. Anything less than that, we let it ride and continue to monitor it. Anything more than 30% increase with addition of more potent medications, then we may have to make an adjustment. But you tolerate. If serum creatinine goes up 20%, oftentimes those patients will actually do better long term. It actually shows that we're making a hemodynamic difference. So my time is up for my lecture here, but I really want to focus on these take-home points for you today. Number one, resistant hypertension has updated guidelines regarding its management, and I would encourage you to take a look at them. Number two, properly defining and diagnosing resistant hypertension is really a key, and that includes measuring out-of-office blood pressure. And then finally, management is multifactorial. And if you're not talking about lifestyle with your patients, or at least having someone talk to them about lifestyle and just prescribing medicines, you're not going to get where you need to be and get patients controlled. So with that, I really appreciate your time and be happy to take any questions that you may have. Thank you very much.
Can we stop the recording, please? Yeah. Dr. Leffin, it was a very informative and very excellent presentation. Thank you very much for that. And so we will be live on 8th of November, and I will be telling you the exact timing for the sessions. So I will request your presence on the scheduled date so that we can take the questions from the participants.
Yeah. So send me exactly when that is.
Sure. I will be sending you the exact details of the session.
Okay, great.
Yeah.
Thank you.
So thank you very much. Thank you, doctor.
Okay, thanks everyone. Appreciate it. Bye-bye.
Yeah, thank you, doctor. Thank you very much.
Bye.
Into bhai, good night. Hello. Hello, Mintu bhai, hello.
हाँ बोलो
Good night.